And all present here. It's a privilege to address such wonderful gathering. So I will be talking about cancer genetics and genetic counseling, which is a frontier in cancer management. So before starting, I would first like to introduce myself. So I am Trisha Mondal, having a degree in medical biotechnology. So after doing my master's, I practiced genetic counseling extensively, and now I am working as a genetic counselor in a company called 4Base Care. So introduction, as in I would like to explain what is cancer and why as to genetic counseling is so much important in cancer genetics. So cancer is fundamentally a genetic disease that arises from the accumulation of DNA mutations in cells. Most cancer-causing genes are somatic. So when we talk about somatic, we essentially means that some mutations that can be acquired during a person's lifetime. But there are small percentage of mutations that are inherited and which are also known as germline mutations. And these actually has the significant risk to increase cancer. So thus, this basically leads to hereditary cancer syndromes. So here comes cancer genetic counseling or genetic counseling as it provides a personalized cancer risk assessment and guides informed decisions about screening, prevention, treatment options for individuals and their families. This slide basically talks about BRCA1 and BRCA2 cancer risk. So basically, when we talk about BRCA genes, so these are two very essential genes which are responsible for causing ovarian cancer, breast cancer, pancreatic cancer, melanoma, and prostate cancer. Why? Because they are like the repair mechanism. They conduct the repair mechanism in the DNA. So if there is any error in this repair mechanism, genetic mutation in these two genes might happen, which might lead to susceptibility of these all cancer which are mentioned in the slide. So I would just briefly talk about when we find BRCA1 mutation in ovarian cancer patient, we have seen that there is 39 to 58% of increased risk of getting a positive BRCA1 pathogenic variant. Similarly, when we see about breast cancer, so here BRCA1 almost have 60 to 72%. So I would skip to my next slide. So at 4Base Care, we have dedicated 3 genetic testing panel, which actually is for germline or the hereditary aspect. So first we have the germline plus panel. Here we basically analyze total 163 genes, which is one of the most comprehensive panel as because it covers all the genes like the MMR, the HRR, everything is covered. Then we have the HRR genes. Here basically we cover 14 genes which are based on the homologous DNA repair pathway. So, and the last one is the target BRCA1 and BRCA2 genes. So this panel is particularly dedicated to identify any genetic mutation in BRCA1 or BRCA2 gene. Now we have a look at MLPA. So MLPA is known as multiplex ligation independent probe amplification, and this is a PCR based technique, as in this is known as actually the short form of polymerase chain reaction. So what is the basic mechanism? I'll just briefly explain. So when we have a DNA, so DNA will have 4 letters, as in ATGC. So inside this DNA, when we want to conduct the test, at first we will take the patient sample, and from there we will take down the DNA. And upon taking the DNA, we will break down the DNA into two parts. Okay, so basically the idea is DNA is double helical structure. So we will try to provide heat so that the DNA actually is breaking down into two strands. So when the DNA breaks down, then there is something called DNA probe. It is basically a synthetic probe that it is getting basically attached to our gene of interest. Let's say we want to find a mutation or anything as in BRCA1. Let's just take in that example. So now this probe goes and binds to that particular region in the DNA. So if we see that there is any missing part of the gene, the probe will not bind to that particular area of the DNA. So this basically will give us a very light signal. So light signal when we get, we can say that there is some deletion in the DNA, and if we are getting higher signal, as in if there are multiple copies of the gene present, so then we can say that the signal is higher. So basically the idea is in NGS will miss some part of this deletions or duplications which are quite large, but MLPA is very much effective here. It will identify large deletions and duplications which are often missed by the NGS, which is next generation process. So this is basically performed when a person has synchronous cancer, as in it will have the dual cancer. Next, based on whether it's NGS or MLPA, we will have three types of result. It is positive, negative, or VUS. So in case of positive, we get to see that there is an increased cancer risk, of course, and then after that, there is a increased screening process that goes on. As in, the patient comes here, we will try to understand what are the NCCN based guidelines that could be suggested as a management basically to the patient, and we will thus provide those management plans. And if there are any preventive options, we will also offer, and if there are any cascade testing that can be given to the patient, that will be also be informed to the patient and their caregivers. And in case of negative, there is a lower chance of hereditary cancer, as in we did not find any sort of mutation, and this may remain due to family history. So there could be possibility that the patient might have a history, but the result is coming as to negative. So we cannot eliminate here. Actually, genetic counseling is very important because we need to analyze a person's family history by taking down the pedigree, and that will help us to identify what further testing can we suggest to the patients. Now coming to the third kind of report that we can expect, that is the variant of uncertain significance, or also known as VUS. So we usually say that this is a gray line. So it's neither positive or non-negative. So then what is it? So when we get a VUS report, it usually means that the gene which we got in the report, with that particular gene, there isn't enough evidence or study being conducted to say whether that gene could be of something significant, or maybe that particular gene is causing the disease. So that's why the whole picture or the whole status of the gene is quite unclear. So that is the reason when patients come to genetic testing, genetic counseling to us, we don't usually change any management plan, or we provide any management plan to them. We usually say, go to your treating oncologist or clinician and just do a regular follow-up, because giving them any management plan just based on a scenario which is very uncertain, that is quite unethical. So what we can do is, for VUS, there is something called reclassification. So one can always Since in genetics and genomics, every day new studies and discussions are happening all around the world. If any evidence or any report gets updated with the gene of interest that we are talking about, that is being reported to the patients. And then based on that, prompt actions can be taken accordingly. So now coming to the prophylactic measures, here are certain prophylactic measures which are based on NCCN guidelines. So these are basically, prophylactic means that cancer has not occurred yet, but these are the measurements that can be taken. So these are the ones. I will move forward to the next slide, which is the screening. So screening will be again based on the NCCN guidelines. So this is for the patients who have been identified with BRCA1 or BRCA2 mutations. Okay, so moving forward, so now basically I will highlight the main part where genetic counseling comes into play. So first I would like to highlight that at 4-base care, we have something called Germline Plus panel. So Germline Plus panel actually covers 163 gene, which is quite comprehensive. Why? Because it actually covers all of the hereditary cancer-related genes, and we have done this study based on large-scale literature in Asia, and case study reports, case presentations, scientific evidence, and recommendations which adhere to the standard of care guidelines. Now coming to the case studies, the first case study is of a patient where we can see that it's a female patient who is 46 years old. Diagnosis is triple negative invasive ductal carcinoma of breast. Now, just by looking at this pedigree, we can see that the patient's mother was also diagnosed with breast cancer at the age of 35 years, and her sister was also, as in the mother's sister was also diagnosed with breast cancer. So just by looking at this pedigree, we can say that it's a BRCA1 positive case, because it also highlights this is an early onset. So for this, when genetic testing was done, it was found to be BRCA1 positive, and based on that, NCCN guidelines, which are approved measurements present, that was suggested to the patient. For the case study 2, it is one of the rare case studies. Why? Because this is a female of colon cancer, 32 years, and she was having colon cancer, and the report findings suggest of BRCA2. So if we see from her paternal side, her father was also having colon cancer and was diagnosed at the age of 58. And her paternal aunt had ovarian cancer and was also diagnosed with BRCA2 pathogenic variants. So what happens is that right now there is no evidence for BRCA2 being included in the HPOC, that is the hereditary breast and ovarian cancer syndrome genes, because due to lack of study, but this is why this is rare. So for this, two things. One, family history plays a very important role. And the second one is when we are being a bit choosy and we are going for just maybe 15 gene panel or maybe 20 gene panel, we might miss some of the genes of our interest since it's a rare one. So for this one, always a comprehensive testing is suggested, that which I have mentioned is the Germline Plus screening panel. Now coming to the case study 3, this is one of the classic example of Lynch syndrome. So here it's a male patient of 43 years old and was diagnosed with colon cancer at the age of 41, and both of his parents, father was diagnosed with colon cancer at the age of 48 and mother with breast cancer at the age of 65. So just by looking at this pedigree, and also from his paternal side, the influence is more. But for this patient, what is the key gene and why we highlighted to Lynch syndrome, because MLH1 is the gene which is associated with Lynch syndrome. So the patient was identified with that. And also, since from the paternal side, there is quite a high influence and both of his parents were having cancer. So for his children who are like 18 years and 10 years, genetic testing was suggested. So anybody who is 18 or above 18 can undergo genetic testing. So after this, we'll move to case study 4. So this is again one of the classic example of Lee-Fimney syndrome. So in Lee-Fimney syndrome, sorry, I'm over the time, but I'll just take few minutes. So the patient was 39 years old and was diagnosed with dual primary, what is the breast cancer sarcoma and the colon carcinoma. So why it is a classic example of Lee-Fimney? Because TP53 is a gene which is responsible for causing the syndrome. So here again the children were suggested for genetic testing, and one of the significant thing that we can see here is leukemia. Leukemia is one of the cancers which are like the patent, we can say, when we talk about Lee-Fimney, and also the early onset of this cancer. So for this, two things. One, it's a classic example of Lee-Fimney, and second, the children were also suggested for genetic testing. That's all. Thank you so much for your kind attention. Thank you.